And we thought we would have a focused conversation on PPE given its importance. You've gotten several emails in the last 24 hours regarding changes in our practice for masks specifically. And we wanted to give you a little bit of context about that, and also an opportunity to hear from our expert panelists some specifics to help us adopt these new practices safely into our nursing practice and move forward as an organization. So thank you for our panelists for being here this morning with us. I'd just like to say a few minutes on the goals of the organization. And I think it's really clear in the last several weeks to months that our commitment is to keep great care being delivered to patients, to save as many lives as we can. That's always true to our mission, and also to keep everybody safe in doing so. We've been thoughtful behind the scenes, securing and sourcing many different ways to get PPE for you. Face shields, masks, goggles, gowns, etc., and always looking at the next way in which we can increase our coffers for PPE. It's been through the great work of our supply chain team at Tufts and at Wellforce, but also through many contacts that many of you have provided and donations to the medical center. So thank you for that work. Just reading some notes here. This is so important. I don't want to forget anything. So we are always thinking ahead about our PPE count. And we believe practices today determine what we're going to have tomorrow, next week, and the week after. And that's been our model since we've started this. There are no changes in the CDC recommendation, even though we're recommending changes right now in our practice. No change in our enhanced droplet precaution standard either. So you're not going to see signage change. And just a note that because we're increasing our sources of getting different PPE pieces, it's going to look different going forward. And the products we have today, we believe in, they're reliable, and they're going to look different maybe next week and the week after. And thank you for being open and so adaptive to learning how to use different PPE products that we're giving your way. We know it's a lot, but you've also done a really great job adapting. But just a note that we're going to continue to ask you to adapt. We have a few expert panelists with us today, so we thought that we would get started right away and giving them time and opportunity. Let's see. So I think just introducing the panelists. Everybody knows Amy Lund. Amy Lund is back on the nursing leadership team during this COVID pandemic. Is really my right arm for PPE liaison with the nurse leaders, and she's at all the tables when we discuss anything PPE. So thank you, Amy, for this great work, and thank you to CDI for lending her back to us. Deborah Martinez is our director of central processing. Deborah leads a team and has this wonderful goal of just doing whatever the organization needs. So we're going to have her share a bit of what her work is and her role. And then we have Karen Dowler, who is currently the nurse manager in our PACU areas, who's stepped back into being infection preventionalist. And we have Suzanne Menninger. Everybody knows Suzanne, who's with us as infection prevention as well. So I can't remember, we've redone the schedule a bit. Is it Karen or Suzanne? Whoever wants to take the lead. Suzanne, start it. You've got the floor. Thank you.
Okay, we're just going to share our screen.
Beautiful.
So I wanted to take a step back because I know this could be very confusing for everybody, why we keep changing PPE, why we keep introducing new terms. But this is basically what happens in a pandemic. And you already understand about bed capacity because obviously we've been dealing with that for a couple of months now. But this is how it's also applied to PPE. So you have your conventional capacity where you basically provide patient care. Oops, hold on. You provide patient care without any change in daily practices. You have all your guidelines from the CDC, you have your PPE and all your general infection prevention and control plans. Then you have contingency capacity. And these measures may change daily standard practices, but it doesn't have significant impact on the care delivered to the patient or the safety of the healthcare personnel. And sometimes you use these practices temporarily during periods of sometimes planned shortages of supplies. And then you have crisis capacity. And that's when you start to use strategies that are not your US standards of care. And sometimes you use combinations of measures to provide a different protection than what you're normally used to. So we're going to give some examples of that using face masks just to help people understand how this plays out. So your conventional PPE. Everybody knows this. Normally you have your single use and your reuse. We always say use it and discard it. Sometimes people say one and done. And then you have your things that are reuse, and they're actually designed to be reused. They're built that way. So we have, that's the practice of using PPE, then removing it. It gets stored and you use it again, usually with decontamination if not kept clean. So an example of a single-use product that we use every day is gloves. And an example of a reuse that we use every day is gowns. So those gowns get used, we take them off, we send them to Angelica, they come back clean, we use them again. We also have engineering controls. So we have negative and positive pressure rooms. We have ventilation systems that provide air movement. We have private rooms. So this is what you would put your normal patient on that needs precautions. Sometimes we have temporary shortages or back orders during these times, and we might buy our usual supplies, but a different brand. So you may temporarily see orange gloves instead of clear gloves, but the product does the same thing. When you're in contingency PPE, this is when you need a strategy to get through until your supply chain is restored or your census returns to normal. You actually might adapt products from other industries that still work the same but look a little bit different than the ones that healthcare providers usually get. And I'm going to talk about reuse in this context because this isn't like where you just take your yellow gowns, you send them to be laundered and bring them back. You might have limited reuse of PPE that is typically single use. For example, reprocessing N95 respirators. Now, when you get into a crisis situation, you might have full reuse of all PPE without any kind of decontamination if it's that bad. Now, if you look at your engineering controls, you might have limited negative pressure rooms, and you might even have alternate care sites with makeshift rooms. But what I really want to talk about today is extended use, because that's sort of the term that we're trying to introduce this week. And extended use is the practice of wearing the same PPE for close encounters with several patients without removing it. We're going to use respirators as an example. So N95 filtering face piece respirators, they cover your nose and your mouth, and they control exposures to infections that are transmitted by the airborne route. NIOSH approves them for employees. They also approve other face filtering respirators that are at least as protective as the N95. An example of this is the PAPR, the Powered Air Purifying Respirator. And this is a device that provides the same protection as your N95 through the use of HEPA filters. So you see that these are two products that do the same thing but use a different technology. So when we talk about these respirators, we're talking about extended use for N95s. So we're not saying to reuse it. So we're not saying to take it off, store it, and come back and use it the next day. But we're saying once you put it on, try to keep it on for as long as possible, even if airborne protection is not needed. So if you have to put it on to go into an airborne room, and then you're coming out, and you're going to go into an enhanced droplet room like a few minutes later, just keep the N95 and use it for the enhanced droplet. When doffed, we're now saving these kind of masks for CPD for future reuse. So these are products that are not able to be cleaned on the unit. If you look at the other respiratory protection that's designed for reuse and extended use, again, once you keep this on, you might as well keep it on for as long as feasible. And you can defer cleaning until doffed, and we'll give some examples about that. But once you do take it off, it's cleaned and stored. Now the PAPR is actually cleaned and stored on the unit. And the new ENVO mask that we're bringing in is actually not cleanable on the unit. That's going to be cleaned in CPD. But it kind of works on the same principle. It's designed to be reused. I want to go through a couple of clinical scenarios and see if this makes sense to people. So we have an RN who's wearing a PAPR, can actually care for multiple patients with the same face protection on. We feel that's safe because, number one, the face protection does not come in contact with the patient, so the RN can safely move from a COVID positive to a COVID negative or PUI or a patient that's not even in consideration to be COVID infected. Number two, if the patient happens to touch the face protection, the RN should clean the patient's hands. If the RN touches the face protection, he should clean his hands. And the RN can keep the PAPR on in common areas following the same principles of non-touch or touch preceded and followed by hand hygiene. But when the PAPR is finally doffed, it should be cleaned per protocol. CCT wearing an N95 covered with a face shield enters the room to assist a patient to the bathroom who had just received a nebulized medication. The N95 protects the CCT from breathing in potential residual aerosols. The N95 should remain.
Oh,
I think Suzanne just froze. Can anyone hear her?
no.
Okay. So I'd hate to move on right in the middle of this. This was really helpful. Oh, there they
There
are.
she is.
Oops.
And she's back.
Oh, was the slide off?
No, we couldn't hear you at the CCT entering the room.
Oh, okay.
It was the thrilling. We were all in suspense. What's the CCT going to do?
Okay, let's go back to that one. Hold on.
Okay.
All right, so the CCT wears the N95 covered with a face shield and enters the room to assist a patient to the bathroom who had just received a nebulized med. So we need aerosolized face protection for that. So the N95 protects the CCT from breathing in potential residual aerosols. The N95 should remain on when the CCT exits the room. So even if the rest of the CCT's assignment is just enhanced droplet, like our thought is to preserve that N95, just keep wearing it. You know, as long as comfortable. And, you know, if the patient touches the N95, we can't really clean that, so the CCT should remove it at the end of the encounter. But the CCT can keep that N95 on in common areas, following the same principles of non-touch or touch preceded and followed by hand hygiene. You know, and we're not going to touch each other's faces, so that N95 doesn't pose a risk to anybody. And I do want to remind people, like, this virus has no mode of mobility on its own. So it can't crawl, it can't, you know, slither onto something. It has to be transmitted either on some kind of body fluid or picked up by hands. So wearing it on your face and not touching it is going to be safe for people. And we do want to remind, when the N95 is doffed, it should be put in the receptacle for CPD. And then if we have a CRN who is wearing an ENVO mask, enters the ICU room of a COVID positive patient to assist the nurse, then leaves the ENVO mask on for the rest of her shift if possible. The ENVO mask cannot be wiped on the unit, but it doesn't come in contact with the patient, so the RN can keep it on in case help is needed on another patient. They can also leave the unit with this ENVO mask on, and the same touch/hand hygiene rules apply as above. And then I did just want to share this little note that we got from one of the students at the Kingsley Montessori School in Boston. It says, "Dear healthcare workers, thank you so much for all you have done in this global and worldwide issue. I know I am not the only one who appreciates you so much. Thanks to you, many people who have been affected by this pandemic will be able to be healthy again. You inspire me to do what is right and help other people. I appreciate you because you have helped keep my family, friends, and I safe from harm during these hard times. Thank you for all that you do." And that's what Ryan says, and that's what our whole infection prevention hospital epidemiology says also. And I'm going to go to Karen next to tell you about some sort of do's and don'ts. And please pay close attention to these, because these are all the things that will keep you safe.
Thank you, Suzanne.
Thank you, Suzanne. Good morning, everybody. If I could just add, that letter was written by a sixth grader. So that was pretty articulate, right? Okay, so just a few things. I think Suzanne explained the theory and the rationale behind extended use. I just want to go over some do's and don'ts, because when people are going to be using this principle in practice, we just want to keep them safe.
Karen,
So,
sorry,
yes.
Karen, if you guys had more slides, we can't see them anymore. If you, when it signed off, just in case you thought we were seeing them.
Yeah.
All right, we keep losing our signal.
Hey, we can see them. delete the share screen. Okay, great. As I was saying, taking those principles and putting them into practice is the most important thing in keeping people safe. So we kind of organized this into a few do's and don'ts. We thought that was kind of familiar to people that we've done before. So the do's are, it's okay to wear it between patients without the cleaning. That question has come up multiple times. But you do need to remove your gown and gloves. Extended wear applies to the mask, the facial protection, and the eye protection. Gowns and gloves still need to come off. Hand hygiene still needs to be done. Some of this is going to be a little bit repetitive, but that's probably a good thing in this environment. Wash your hands if you come in contact with any of the PPE. We recommend people not touching their face. If you watch people, and I do now, we touch our face 1,000,000 times a day. My friends tell me, stop it. I mean, you're constantly touching your face, your glasses, moving your hair. That, as Suzanne said, is a mechanism for transmission, is getting the virus on your hands and then touching your eyes, your nose, your mouth. So we have to be really diligent about not touching that mask. And if you do, immediately wash your hands. It needs to really come as a high priority. We had yesterday spoken to some nurses on one of the floors, and I was so fortunate that one of our staff up there actually shared personal experiences to make it real. That it's not that we're being nitpicky, it's that this can happen and you can get sick, and we don't want that to happen. So it's on the mask, don't touch it and then rub your eyes. That's really important. Always, if your patient touches it, again, you want to assist them with hand hygiene. Soap, water, CalStat, wipes, whatever you can use. You want to take any mask off if it becomes damp, soiled, damaged, or in the case of an N95, if you're having any trouble breathing, and you feel like it's not, giving you a good seal, it needs to come off. You should take it off, doff it if you're taking a break. If you're visiting any food establishments, you should follow established doffing protocols. Questions came up about, with PAPRs, do I still clean it for the 2 minutes inside and outside? And our answer is absolutely yes. When you're ready to take it off, follow the established protocols that have been developed for doffing and cleaning. Those have not changed. Conserve per protocol. At least a couple of weeks ago, we began saving these masks and goggles and face shields in anticipation of the reprocessing for trialing and then for actual use. And Debbie's going to elaborate more on that, I'm sure. But there are designated collection devices for each of these. Originally, goggles and face shields, we doffed inside the room, so the collection device was inside the room. With extended wear, that may look a little bit differently because people may come out of their room wearing the eye protection and the face mask. So it can be doffed where appropriate in the utility room, in a receptacle. I think one thing that's important to emphasize is that goggles, when we say that you can extend the wear, it is not on the top of your head, okay? We don't want people doing that. That was seen last night. So these are just teaching moments for us to just get it better. And everybody will be taught how to do a user seal check if you're donning a new or a reprocessed N95. Most of the time we include this in instruction when we're doing the PPE training, but we just want to emphasize that will be part of it. Do I just hit enter? Okay, some of the do nots. Please don't continue to wear it if it's damp, torn, or damaged. Please don't pull it down to your chin if one in a room of a patient on transmission-based precautions. I'm going to loosen mine up now. This is what we currently do to eat and to drink, because the current situation, we did not wear a surgical mask when caring for a patient in an isolation room. Now that's changing. If you're practicing extended wear, and I just wore this mask, whether surgical or N95, in a room with a patient on isolation, it now needs to come off and either go into the trash or into the reprocessing bin. And I have a picture of that to show you. We are going to ask you not to wear facial makeup, as that stains the surfaces of the N95s. And please do not discard PPE that may be recycled. As Suzanne explained, when we're going from contingency mode, we don't want to get to crisis mode. We don't want to get there. We want to have as much of the supply as we can. So people need to be diligent about that. This one? Okay. So this shows exactly what I was just speaking to. Universal masking. Again, the mask never got extended outside of a patient on precautions. So it was acceptable to pull it down to your chin to eat or drink. Extended use? No. That mask will now have been in a room with a patient on precautions, and we do not want it at your chin while you're eating and drinking. So that's a real strong point for you to emphasize with all the teams out there. Gina Hale, I don't know if she's able to join us, so I'm going to say a few words about fit testing, and if she jumps in, she can certainly speak to it better than I can. During the outbreak, annual fit testing has been lifted. So you're getting your fit test with your flu shot or on your birthday, that requirement from OSHA has been lifted. However, as this crisis continues and our supply diminishes, we have gotten different types of N95 masks. And there's allocation teams out there determining which location gets which type of mask. For example, the MVO mask that Suzanne referred to earlier, yesterday went to North 6, MICU, and the emergency department, I believe. And there are more plans for different masks for different areas. You need to be fit tested to the mask that you're going to use if you're going to be caring for a patient that's either suspect or confirmed COVID. So if you've never worn an MVO, but you have worn an 1860, you still need to be fit tested to the MVO. It's the same process. Gina Hale's team, in conjunction with a company called Triumvirate, are here all week through Sunday night. She's got a schedule published of fit testing, and that will occur in two different mechanisms. On the units, the MICU, the North 6, and the emergency department, as well as she's got some central locations. I believe it's on Atrium 4 with designated times. That's around the clock until Sunday night. Additionally, fit testing can be obtained by calling the command center. The number is up there. The command center will reach out to environmental safety if it is business hours, and the PPE support team picks that up off hours. Many of us have been trained to do fit testing on spot, on the moment, to be able to assist with this need. Just want to highlight that everything that we are talking about has had multiple teams working on guidance sheets that they start out with like a little bit of an introduction, and then they're bulleted key points. This multidisciplinary of infectious disease, infection prevention, nursing, administration, worked on these forms, and they are on the COVID page under PPE resources, and I circled what they look like. I would encourage everybody to at least print them and have them handy, as this is a new rollout of the extended use of PPE. We do want to remind everybody that this is information only for
Thank you. Thank you, Karen. Are you all set?
I think I am all set. Do you have any questions?
We're going to hold the questions and ask people to log them in the Q&A and go right to Deborah Martinez. Thank you for such a crisp overview and really, really clear, providing a lot of clarity to all of us. I'm getting a lot of text messages saying this is outstanding information and really understandable. So thank you both very, very much. Deb, hello.
Good morning. Thank you for having me here today. I always wanted to be a newscaster or something, but I don't know. Anyway, so just to put people's fears at ease about the reprocessing in-house, I want everybody to know that, you know, we didn't make this up here in CPD, that we actually followed some of the studies that have gone out, like the University of Utah came out with a study. And we also got clearance from the FDA and also from ASP, who is the manufacturer of our SteriRad machine that we're actually using to sterilize these masks. So it's hydrogen peroxide gas plasma that we use. So I just would like to interject, though. I did see a question about makeup. I was going to talk about that. Yes, so please no makeup, but that does include creams and moisturizers. That will actually get into the mask itself and I'm not going to be able to remove that. So it's going to, you know, we're going to end up having to throw that away. We've thrown away about 150 masks because of makeup. And we really need to be mindful of that so I can keep providing you a quality product throughout the next few weeks. So what happens with us when we get your masks? We pick them up. We have a separate place where we inspect them. We make sure that there's no visible soil on it. We make sure there's no rips, and we mark it ready for sterilization. So then it goes into our sterilizer, and then when it comes out, it aerates for 4 hours to make sure there's no residual H2O2 on the masks. Then we bag them. So this whole process is done in a way that we're not going to recontaminate the masks, and to make sure that you guys have a quality product from us that you can feel safe using. I would wear these myself if I had to. So I want you to feel comfortable with that. We've done in-house, and this is just a number from right now. We have many, many more that I need to count, but we've done over 1,600 masks in-house. We've sent out about 677 to the outsourced company, Battelle, and we're using the same process to reprocess these masks. So we'll be getting those back on Saturday. But the team here in CPD is ready, willing, and able to do whatever they need to do to make sure that you folks on the front lines have what you need. And, you know, we take pride in what we do, and we're glad that we're able to help out. So that's what I got.
Deb, thank you and your team. You're always there. You're rising to the occasion. And I know when we started collecting the masks and reprocessing the shields, got a lot of positive feedback from North 7 communities saying, like, we never met these people before, and now they're our best friends. They're looking to make sure we have enough face shields. They're coming, they're asking good questions, they're giving us direction, and they're bringing back product. So another example of the organization really standing up, teams together and working towards a common goal. So thank you very much for re-engineering your work so that together we have the products we need for safe patient care delivery. So it's towards the end of the hour. I think what we're going to do is take some questions we got earlier today, those that are listed in the Q&A, and have a follow-up presentation with this video and the questions and answers today. Everybody on this call has been extremely, extremely informative to our nursing community. We would love to make a recommendation that every nurse watch the presentation by the three of you. Feel like it can save a lot of time because you did a really nice job, you know, skinning a lot of information down into the basic facts, as well as putting it into the important context of why we're here right now and why we're shifting gears a bit. So thank you for that framework and that information, and certainly all of your 24/7 worry and professionalism. So thanks, everybody. Have a wonderful day. We're going to turn this around quickly so your teams can have access to it. And thank you all again to our panelists, and have a wonderful day, everybody. More to come.